The central diagnostic tool in interstitial lung disease is a high-resolution CAT scan. When we categorize the HRCT, there are four buckets that we typically will put patients into in terms of the morphologic appearance of the HRCT. There's a UIP pattern, a probable UIP pattern, a indeterminate pattern, and the fourth pattern is alternate diagnosis suggested. When we say alternate diagnosis suggested, we mean something else rather than IPF. So UIP stands for usual interstitial pneumonia. I won't get into the history of how that name came about, but what is regarded as a UIP pattern is what we term subpleural reticulation, typically at the bases, accompanied by honeycombing, as well as possibly traction bronchiectasis or traction bronchiolectasis, with atypical features excluded like cysts or consolidation or ground glass infiltrates. A probable UIP pattern is all of what I mentioned, except there's no honeycombing, but there should be traction bronchiectasis or traction bronchiolectasis. An indeterminate HRCT is kind of a little bit of a wastebasket term where you can have subpleural reticulation, no honeycombing, no traction, and maybe the distribution is a little bit atypical. IPF specifically is a basilar disease with a peripheral predilection. Alternate diagnosis suggested, meaning we think this is something else and not IPF, is if you have cysts, consolidation, nodules, central distribution, upper lobe distribution, all of those things will enable you to put the patient in the bucket of alternate diagnosis suggested. Now, sometimes in the appropriate clinical context, you can make a diagnosis based on the HRCT, especially if it's a UIP pattern, and in many cases, if it's a probable UIP pattern, as long as the pretest likelihood is high enough that this is going to be IPF. And sometimes even with an indeterminate scan, if the pretest probability is so high for IPF, sometimes even with an indeterminate scan, you can make a diagnosis of IPF. Now, there are those cases where there's uncertainty and a gray zone and one isn't certain what the diagnosis is. And in those cases, a surgical lung biopsy might be needed. In my experience, that's probably about 10 or 15% of our cases go on to a surgical lung biopsy. And if we talk about what the surgical lung biopsy shows, it's kind of parallel to the morphologic description of the HRCT, where we categorize pathology as a UIP pattern, probable UIP pattern, indeterminate, or alternate diagnosis. And typically, when we decide on the final diagnosis, there's a trio of disciplines that come together. There's the clinician with the history and physical exam, taking into account the radiographic appearance, and then the third being the pathologic appearance. So pathology by itself is not the gold standard. The gold standard, as we talk about it today for making a diagnosis of IPF, is a multidisciplinary discussion between those three disciplines.